Folks, I'm Kirat Singh. I'm one of the orthopedic surgery residents at Vanderbilt. I'll be talking to you about shoulder exam, imaging, and anatomy. This is the first segment in a two-part series. The second segment is going to focus on common shoulder pathology ranging from osteoarthritis all the way to rotator cuff tears. The goals of this talk are first to talk to you about shoulder anatomy. We'll follow that with imaging and then talk about how to do a shoulder exam. The shoulder joint's very unique in that there's a lot of motion there. It's in contrast to the hip joint. Hip joint has some stability but decreased range of motion. The shoulder itself is more like a golf ball on a tee and relies a lot on soft tissue for stability. When you think of the shoulder joint, know that it's four separate joints, not just one ball and socket joint. There is an articulation between the scapula itself and the chest wall, and that's the scapulothoracic joint. A third of your motion, at least in the abduction plane, comes from that. You also have your glenohumeral joint, which you commonly think about, and then your acromioclavicular joint, as well as the sternoclavicular joint. Let's spend a second and look at the scapula itself. It's a flat bone, has 17 muscular attachments. And on yourself, you can feel various portions of this. There's the inferior angle, the bottom portion of it. You can feel part of the coracoid along the front side. And then you also have the scapular spine, which you commonly think about as your shoulder blade in the back. There are multiple ligaments in and around the shoulder. And there's also a whole bunch of muscles around there that stabilize the whole thing together so that the golf ball doesn't fall off the tee. There's the joint capsule, and that's sort of a big saran wrap of tissue with various portions that are thicker than the others that go in and around the joint itself. There's the labrum, which is a lip of tissue which deepens the glenoid socket, and then you have various ligaments, the acromioclavicular, which goes from the acromion to the clavicle, the coracoclavicular, which goes from the coracoid to the clavicle, as well as the CA ligament, which is the coracoacromial ligament, that help keep that ball in the socket. There are dynamic stabilizers of the shoulder joint, and these are the muscles that will hold that ball in the socket. Let's start with the rotator cuff. The rotator cuff is four different muscles. On the front side, as seen in the picture to the left, you can see the big subscapularis muscle, which drapes along the front side of the glenohumeral joint and helps with internal rotation of the humerus. On the top of the glenohumeral joint, as seen on the picture to the right, you have your supraspinatus muscle. It's supraspinatus, meaning above the spine of the scapula, and it goes up and over the glenohumeral joint, helps with abduction of the shoulder joint. And then you have on the backside the infraspinatus and the teres minor muscles, which help with external rotation. All of these muscles combined together will really help pull that humerus right into that glenoid socket. In addition to the rotator cuff muscles, you have a variety of muscles on the front of the shoulder. Starting with the pec minor muscle, attaches directly on the coracoid and then usually along ribs 3, 4, and 5. You have coracobrachialis, which is a muscle which starts from the coracoid and goes to the brachium, sort of the mid portion of the arm. And then you have the two heads of the bicep, the long head and the short head. And these come together in the mid-arm to attach distally along the radial tuberosity. The long head of the biceps actually has a place in shoulder pathology because it actually travels inside the shoulder joint. So if you're tiny and you're really swimming around in that glenohumeral joint and you look up, you will see that tendon which starts from the labrum and the supraglenoid tubercle. It starts there and actually goes intra-articular and then passes into the intertubercular groove, which is the proximal portion of the humerus, and goes down and starts heading distal. Anytime you're having bicipital groove pain, think about the biceps tendon as being a possible contributor. Moving past anatomy, looking at imaging, you can always start with x-rays. There's the true AP view, and AP view is something that we usually think about as a x-ray that's obtained directly with the beam going from A to P, or P to A for that matter, and that's not going to do you justice in the glenohumeral joint, because the glenohumeral joint, as seen in this image, is really offset, and you have to shoot about 30 degrees off the midline because of the way the scapula sit at an angle, and that's how you can shoot a true AP. The lateral view is just looking at the shoulder joint from a direct lateral view. It's also called the scapular Y sometimes. Then you have the axillary view, which is shot from below, and you can get a sense of that glenohumeral joint in all different kinds of planes. It's important to be able to obtain multiple different views, because if you just get an AP, as we do here, you can see that the glenoid isn't quite concentric with the humeral head, although maybe the humeral head is slightly subluxed inferiorly. That's why 90-degree orthogonal views are essential, because once you get an axillary view, you can see that the glenoid and humerus are not actually concentric. Here are those red lines which will show you the joint and the humerus a little bit better. And you can see that the humerus is actually dislocated. So summing up plain films, you can get AP, lateral, and axillary views, which will help you look at the shoulder joint in 90-degree planes. A CT scan is helpful anytime you want to look at bony architecture. This is in the case of a proximal humerus fracture, a scapula fracture. Another good time to get a CT scan is if you're looking at the SC joint, the sternoclavicular joint, because that's a joint that's not really that well seen on plain films. And as seen in this CT scan, you can see that the left side, actually the SC joint, is dislocated with the clavicle sitting posterior to the sternum. And so in a scenario where you need to get a better assessment of the anatomy, the CT scan is helpful. Always great for bony architecture. Next, moving to an MRI, whereas CT is great for bone and MRI is great for soft tissue. Rotator cuff tears are seen on these MRIs. Even on the image I have projected on the screen, you can see that the supraspinatus muscle is draping up over the top of the humerus and is lifted off where it actually needs to be attached. And that's better shown with that arrow. And it's lifted off that area, which is now bare, and that's illustrated with that red perforation. And you can also get a sense of whether the tear is acute or chronic. In an acute tear, one that just happened a couple of days or even a week or two ago, the muscle body is still going to be thick, versus a chronic tear in somebody who's been sitting on it for 6 months or so. The muscle body will be atrophic and will be infiltrated with fat. Biceps pathology, whether that's tendonitis or the biceps tendon ruptured, is another great thing seen on MRI, as well as labral tears. Again, the labrum is that lip of tissue right around the glenoid, which deepens the socket. That can be seen in sporting events where people have dislocations. They can tear that labrum. And you can put dye directly into the glenohumeral joint and then get an MRI, and that's called a MR arthrogram of the shoulder, and that helps you better evaluate the labrum. And then finally, if there's a concern for a tumor, you can get an MRI. So it's good for soft tissue masses. Let's talk about the shoulder exam itself now. Anytime you're doing an exam, particularly in orthopedics, it's great to have a system so that you don't miss important findings. You start first with inspection, move to range of motion testing, follow that with strength testing of the muscles, and then finally you can do special tests focused on the patient's particular complaint. Start first with inspection. Look at everything from past surgical scars down to atrophy of any particular muscle group, whether the joint is swollen, whether there's erythema in and around the joint. And look at the joint from the front and from the back. The back will give you a sense of how high or low the scapula actually sits on the thorax. In cases where somebody's had a previous trauma or a nerve denervation, the scapula may or may not sit appropriately along the thorax. After the inspection, you move to range of motion. Range of motion testing should be done both actively and passively. You can have them start by doing active motion, and then you yourself will perform the passive range of motion. Start with forward elevation. You then do internal and external rotation with the arm at the side, and then you do internal and external rotation with the arm at 90 degrees of abduction. Let's start first with forward elevation. Forward elevation normally is about 160 to 170 degrees, and have them first do it actively. Look at them from the side, as is shown in this picture, and measure that angle between the midline of their body up to how high their arm goes. Stand behind them and see how their scapula is also moving. Interestingly, in some cases, if they've had denervation, their scapula will lift off their thorax and you can see winging. What exactly are you testing with forward elevation? You're seeing that their abductors and their forward flexors of their shoulder joint are still intact. In addition to that, if their inferior capsule, again that saran wrap around the glenohumeral joint, if that's very tight inferiorly, the patient's going to have a hard time with forward elevation. Again, like I already said, look at the patient from the backside as well as they're lowering their arm from forward elevation. This patient on the right side has lifting of the medial portion of the scapula, and you can see that in cases of long thoracic nerve palsy. After you've done forward elevation, you can then do internal and external rotation testing with their arm tucked by the thorax. So here this gentleman had the elbow stabilized and was instructed to externally rotate. You can tell them, show me how big the fish is, and get a sense of external rotation on both sides. Again, the elbow should be stabilized so that they're not lifting it out in space and giving you different measurements. Have their forearm supinate, and that'll also help with their elbow staying in place. What you're testing here is really how tight their anterior capsule is and whether the external rotators of the shoulder, which are infraspinatus, and the posterior portion of the deltoid are competent and working. Then what you can do is do internal rotation testing with the arm again at their side, and look at the patient from the back and have them reach for their wallet, and they will essentially do a motion like this, and this will give you a sense of how much internal rotation the patient can perform based on how high they can go up on their back. Most people can go up to somewhere along the mid-thoracic spine. As a landmark, roughly, the tip of the scapula sits around T10, and the spine of the scapula sits around T3. People who have severe capsular tightness, particularly posteriorly, will not be able to do this. This motion, this internal rotation motion, is testing really the integrity of the subscap muscle. Next, you measure internal and external rotation of the shoulder joint with the arm abducted at 90 degrees. And the purpose of this, as you'll see, is to test a different set of muscles altogether. So have them abduct their shoulder like the gentleman is doing in that image. Stabilize the elbow to maintain that 90 degrees of abduction. And then have them externally rotate. And that motion is really testing the teres minor muscle. And as well as the inferior capsule. So if the inferior portion of the capsule is too tight, they're not going to be able to perform that motion, or if their teres minor is weak. Then in the same motion, instead of going externally, you have them internally rotate. Again, abduct the arm to 90. You support the elbow and have them internally rotate their arm. And this will give you a sense of how tight their posterior capsule is. That wraps up range of motion testing, and then you can move to strength testing. There are different tests to test the different portions of the rotator cuff, starting with the infraspinatus. The infraspinatus, again, is a muscle that will help you with external rotation. So what you do is you give them resistance when they're trying to externally rotate. So get their arm in 45 degrees of internal rotation, and then have them push against your hand and see if they can externally rotate. Weakness there will tell you that the infraspinatus may be compromised. Next, you can test supraspinatus. And the supraspinatus muscle, again, is the one that drapes along the superior aspect of the glenohumeral joint. And what this does is helps you with arm abduction. So You can do the empty can test where you go like this, as if you're dumping out contents of a can, and resist. You as the examiner give them resistance and they push up against your hand. That tests the integrity of the supraspinatus muscle. Next, look at the integrity of the teres minor muscle. Again, this is the rotator cuff muscle, which comes along posteriorly along the glenohumeral joint and helps with external rotation. So have them in abduction at 90, externally rotate their arm. If they can't hold it there, it's because their teres minor is weak or compromised, because this motion requires that the teres minor hold the glenohumeral joint like this. And if you tell them to hold it like this and they shift back, that's because that teres minor is weak. Finally, the subscapularis muscle is the anterior rotator cuff muscle, which drapes on the front side of the glenohumeral joint. And the function of this muscle is to really internally rotate your humerus. And so what you can do is have them flex the elbow to 90, and you give them resistance as they try and internally rotate. There are two tests, one called the lift-off test, as I'll show you here, and the second one is the belly press test, which also evaluate for the subscapularis. In the lift-off test, you have the patient internally rotate the humerus and put the dorsum of their hand along the lumbar spine, and then you have them lift it off their back. This motion, this lift-off motion, really requires your subscapularis muscle to be intact. If they cannot perform this, the case probably is that there is greater than a 75% tear in the subscapularis muscle. The belly press test is also a very similar test, and this evaluates for the subscapularis integrity as well. Here you look at the patient from the side and have them push directly into their belly. And what you pay attention to is what their elbow and their wrist are doing. Somebody who has an intact subscapularis muscle will leave their elbow in the same place and still be able to belly press. Someone who has subscapularis weakness will try and compensate by really pulling their elbow back in and using that as a belly press test. So if the elbow is shifting posteriorly as you have them belly press, think that their subscapularis muscle may be weak. So finally, after you've done inspection, range of motion testing, and you've done the strength testing of muscles, you can go to various specific tests that'll help narrow your pathology. There are two tests designed specifically to look at the biceps. The first one is called the Speeds test, and this is essentially resisted forward elevation. And so as the patient is trying to lift their arm up in space like this, you as the examiner give downward directed force. And if they're having severe pain in and around the shoulder, and probably in the bicipital groove itself, think about shoulder pathology coming from the bicipital groove. The other test is the jurgis test. And the idea here is that you have them try and supinate their forearm. And this motion really requires that your biceps tendon be intact. When you resist, i.e. if I shake somebody's hand and tell that person, turn your palm to the sky, as I force their palm down, they're going to do a resisted supination movement, and that's going to really tax the biceps. And if they're having pain while trying to do resisted supination, as is the case in that image, think about bicipital groove pain. Another specific test is the cross-body test. This is essentially where you have them adduct their arm across their body. And if they're having severe pain right along the acromioclavicular joint, you may think about AC joint arthritis as the possible cause for their pain. In younger weightlifters, this could be due to distal clavicle osteolysis as well. There are times where impingement is causing pain in the shoulder. So the two impingement tests that I commonly do are, one is the near sign, and here you internally rotate the arm and you passively abduct maximally. And what you're doing is you're really taking that humerus and driving it underneath the acromion. And if they're hurting as you're doing this, it's a positive test. The Hawkins sign is similar. Here you abduct the shoulder to 90 degrees, you flex the elbow to 90 degrees, and then you internally rotate the arm. And if they're hurting, it's because you're really driving that humerus underneath the acromion, and that's causing them pain. Finally, there are tests for instability. And these are called the apprehension and relocation tests. So you have the patient lay down supine, as is the case in this image, and you internally rotate their arm as you abduct them to 90 degrees. Excuse me, you externally rotate their arm as you abduct their arm to 90 degrees, and they will fear that their shoulder is going to dislocate, as is the case in this patient. Then you can apply a posteriorly directed force on the front of their glenohumeral joint, and this will cause a sense of relief, and that's called the relocation maneuver. Finally, when looking at instability, you can do a sulcus sign where you can give a inferiorly directed force along the adducted arm to look for any kind of inferior translation of the humeral head. So what this means is you're really giving a strong force inferiorly along the humerus and seeing if a sulcus, a divot, forms right underneath the acromion. So after doing these various tests, you should get a sense of where their pathology is coming from. You can start with inspection, move to range of motion testing, do muscle strength testing, and then some of these special tests. Thank you.